Hi everyone, and welcome to our module on cervical cancer. Cervical cancer refers to cancer of cervical epithelial cells, and the vast majority of cases, about 97%, are associated with human papillomavirus. So when you're talking about cervical cancer, we're always talking about HPV infection as well. So human papillomavirus, or HPV, is a sexually transmitted cervical infection, and there are multiple subtypes of the virus, each given a number for a name. And in terms of cervical cancer, HPV 16 is responsible for about half of cases, and HPV 18 for about 20% of cases. And then beyond these two subtypes, there are a number of subtypes responsible for a small number of cases. And among sexually active women, there's a high prevalence of infection with HPV. Now, most women will clear the infection within 12 months, but some will have the infection persist. And it's these women in whom the infection persists that are at risk for cervical cancer. The area of the cervix where cervical cancer usually arises is called the squamocolumnar junction. This is the junction where the epithelium of the cervix changes from squamous to columnar epithelium. So the area of the cervix that leads to the uterus, the cervical canal, this is called the endocervix, and it contains columnar epithelium. The outer surface of the cervix towards the vagina is called the ectocervix, and this contains squamous epithelium. And so the junction where the epithelium changes from squamous to columnar, called the squamocolumnar junction, that's where most cervical cancers arise. If you look at this picture on the screen here, the dark beefy red area here is the endocervix, that's columnar epithelium, and you can see the line of demarcation where it changes to squamous epithelium, that's the squamocolumnar junction. You also should be aware that the squamocolumnar junction moves throughout a woman's lifetime. It can be further out or it can come back further in. And this area over which it moves is called the transformation zone. This is an area surrounding the squamocolumnar junction in which the junction can move during a woman's lifetime. It moves from exposure to hormones and other factors, and the transformation zone is the area between the original squamocolumnar junction and the new or current squamocolumnar junction, and 95% of cervical cancers arise here. It's related to the squamocolumnar junction. It's this area where the junction moves over a woman's lifetime. Just to make this very clear, on the left side of the screen is a histology image of the squamocolumnar junction. This is squamous epithelium of the ectocervix here, and this is columnar epithelium of the endocervix here, and this would be the junction right here. And then if you look at this drawing on the right side of the screen, the cervical canal in here has columnar epithelium. The outer surface of the cervix here has squamous cell epithelium, and this is the transformation zone, this blue area here, where the junction moves outward and inward over the course of a woman's lifetime. Some of the important risk factors for cervical cancer are shown on this slide. The major risk factor is human papillomavirus infection. Patients who are immunodeficient are also at increased risk because they can't clear the HPV infection if they do become infected. Cigarette smoking is a risk, so is sexual intercourse at a young age, multiple sexual partners, and a history of sexually transmitted infections. So now let's talk about cervical neoplasia, which can occur in women who have chronic HPV infection. And you should know that cervical neoplasia progresses slowly through stages until cervical carcinoma develops, and that's why we screen for this, because we can treat it in the early stages. The average time from HPV exposure to cervical carcinoma is about 15 years. Recall that the cervical epithelium has a basement membrane, which I'll draw here as a line, and it has cells piled on top of it. Initially, cervical neoplasia is contained by the basement membrane. We call that intraepithelial neoplasia. It's growing only above the basement membrane. When it breaks through the basement membrane, we then call it cervical carcinoma. As the neoplasia is growing within the epithelial layer, we can identify it by a biopsy, and there are a number of ways to classify the degree of cervical neoplasia. The first way to classify the neoplasia by biopsy is called the CIN system. CIN stands for cervical intraepithelial neoplasia. By this system, CIN1 lesions are low-grade lesions. They are very far away from developing into carcinoma. CIN2 and 3 lesions are high-grade. They are very close to breaking through that basement membrane and becoming carcinoma. The other system for classifying biopsy findings is the Bethesda system. This is the preferred system in modern practice, but the CIN system is still in wide use because it's been around for a long time. By the Bethesda system, lesions are classified as squamous intraepithelial lesions, or SILs. A low-grade SIL or an LSIL is a low-grade lesion far away from becoming carcinoma. A high-grade squamous intraepithelial lesion, or HSIL, is a high-grade lesion about to progress into carcinoma. And so you don't need to know how to classify these lesions based on their appearance under the microscope, but just to give you an idea of the biopsy findings, on the left is an example of CIN1 or low-grade SIL, and you can see that there are some abnormal cells, but mostly the epithelial layer remains intact and looks somewhat close to a normal cervical epithelial layer. On the right is an example of CIN3 or HSIL. You can see that the epithelial layer has been completely replaced by these abnormal cells with abnormal nuclei. This is a lesion that is high grade and very close to breaking through the basement membrane and becoming carcinoma. And so when cervical neoplasia breaks through the basement membrane, we call that cervical carcinoma. And most cervical carcinomas are squamous cell carcinoma, about 75%. A smaller percentage are adenocarcinoma. This happens when the cancer derives from the endocervix, which is that columnar epithelium lining the cervical canal towards the uterus. And cervical carcinoma almost always occurs in women with HPV infection, as I mentioned earlier. Usually it's women in their 40s or 50s who acquired it in their 20s and then were not screened. We'll talk about screening in a little bit, but if women are screened and they have treatment for precursor lesions, it's very rare for cervical carcinoma to develop. And this is a picture of a cervix from a woman with cervical carcinoma. Hopefully you can appreciate that this mucosa here is very abnormal looking. That's how it appears when there is carcinoma present. Usually cervical carcinoma is asymptomatic. It can present as vaginal bleeding. You can imagine that if the cervix looks like this picture on the screen here, it can easily become friable and bleed. Women can also have irregular or heavy menses. Postcoital bleeding is a classic presentation because after intercourse, that can irritate the cervix and that can cause bleeding when there is cancer present. And cervical carcinoma can invade locally to the bladder or the rectum, and this can cause symptoms in those organ systems. So now let's talk about screening for cervical cancer, and we'll start by talking about the Pap smear, also known as the Pap test. This refers to an analysis of a sample of cells collected from the cervix, and the idea is to analyze those cells under the microscope and look for koilocytes. Koilocytes are cervical epithelial cells with large dark nuclei. They look like what's shown on the screen here. And when you see koilocytes on a Pap test, this is evidence that epithelial cells have begun to change in the cervix because of HPV infection. So importantly, this is not detecting HPV infection directly. Instead, it's identifying epithelial cell changes caused by HPV infection. And when a Pap smear test is abnormal, it's usually followed up with a colposcopy, which is an examination of the cervix. We'll talk about this in a minute. An alternative to the Pap smear for cervical cancer screening is HPV testing. This testing also analyzes a sample of cervical cells, but it identifies specific high-risk subtypes of HPV virus. It's not available in all locations. Pap smear is widely available, but HPV availability is more limited. And importantly, it identifies HPV infection only. It doesn't tell you if the epithelium has begun to change because of HPV. That's what a Pap smear will tell you. This will tell you only that HPV infection has occurred. And so there are two ways you can use HPV testing. One is called primary HPV testing. This means testing for HPV alone without a Pap smear, and this is rarely done. And the reason it's rarely done is because a positive test will only tell you that there's infection. It won't tell you whether or not cellular changes in the epithelium have begun to occur. The way HPV testing is more commonly used is as one element of co-testing, which means testing a sample of cervical cells for HPV plus doing a Pap smear. The way this works is if the HPV test is positive, then you know there's an infection present, and if the Pap test is positive, then you know cellular changes have begun occurring in the cervical cells because of HPV. And so in these cases, the testing is followed up with a colposcopy because you need to examine the cervix and do a biopsy to see how advanced the epithelial cell changes are from HPV infection. If, on the other hand, the HPV test is positive but the Pap is negative, then that means you have HPV infection but there are no cellular changes present yet. And in this situation, you can repeat testing in a year, and this allows you to defer colposcopy. The idea is the test is telling you that although HPV infection is present, the cervical cells have not begun to change. That's why the Pap is negative. So you can defer the colposcopy until cells become abnormal in the cervix. So this is a summary slide of the recommendations for when women should be screened. Different groups have different recommendations, and I've tried to summarize them all in this slide. So before 21 years of age, the guidelines recommend no screening. And the idea here is that before 21 years of age, cervical changes and cervical neoplasia are very uncommon. From ages 21 to 29, you can either do a Pap test every 3 years starting at age 21, or you can do HPV testing every 5 years starting at age 25. The guidelines vary depending on which group you're following. From ages 30 to 65, you can do a Pap test every 3 years, or HPV testing every 5 years, or co-testing every 5 years. And then beyond age 65, you can discontinue screening in women who have had 3 normal Pap tests or 2 normal co-tests. However, you may continue screening in certain high-risk individuals, for example, women who are smokers or women with other risk factors. And keep in mind, these are just guidelines and recommendations. Gynecologists will use different screening methods for different women depending upon their risk profile. There are a couple of special populations in terms of cervical cancer screening. For women who are immunosuppressed, they should begin screening at the onset of sexual activity, and they should continue it throughout their lifetime, even beyond 65 years of age. They can either have a Pap test done alone. This can be done every year, and then once they've had 3 years in a row where the Pap test is normal, they can begin to do testing every 3 years. An alternative is to do co-testing every 3 years. Another special group are women who've had a total hysterectomy where the cervix was removed. In these women, they have no cervix, so no screening is indicated unless they've had a prior abnormal result and you think that there may be cervical cancer cells that have remained behind after the cervix was removed. Let's talk about the interpretation of the results of a Pap smear test. It would be nice if the results of the Pap smear test were something like, yes, cervical neoplasia is present. Unfortunately, it's not so simple, and there's a range of results you can get, and you have to know what they all mean. One potential finding on a Pap smear is the presence of atypical glandular cells. This means that the test identified glandular epithelial cells, and the word glandular is key. If you look at this picture on the screen, remember that the outer portion of the cervix here, the ectocervix, contains squamous epithelial cells. So if you're seeing atypical glandular cells, they did not come from the ectocervix here. There's 2 possibilities for where they came from. One is the endocervix, which is what lines the cervical canal towards the uterus. The other possibility is there are glandular cells in the endometrium, so atypical glandular cells can also be from the endometrium in the uterus. Because these cells are atypical, they may represent malignancy, so this result of atypical glandular cells in a Pap smear has to be followed up with additional testing. It's often followed up with a colposcopy, which we'll talk about in a minute, and when you do this, you need to sample the endocervix with a curettage. That means you need to scrape some endocervical cells from the cervical canal to examine them and to see if they are malignant. In addition to endocervical sampling, the glandular cells could also have come from the endometrium. So if women are age 35 or over and they have endometrial cancer risk factors, then this finding on Pap smear is an indication for an endometrial biopsy. I talk about endometrial cancer in the video on uterine cancer, but the key point here is that sometimes women with endometrial cancer are identified through Pap smear, and the way this happens is that you find atypical glandular cells on the Pap smear. Another potential finding on Pap smear is the presence of benign appearing endometrial cells. This means that endometrial glandular cells were identified, but they are benign appearing and not atypical. This is a very common and benign finding in women under 45 years of age, and for this reason, this finding will only be reported by pathologists on Pap smear in women who are age 45 or greater. The reason it's reported in this age group is because there's a small chance it indicates endometrial cancer. What you do for follow-up of this finding on a Pap smear depends on a woman's menopausal status. In women who are premenopausal, usually no further workup is necessary unless the woman has abnormal uterine bleeding or a high risk of endometrial cancer. In women who are postmenopausal, however, when you have this finding on Pap smear, it's usually followed up with a hysteroscopy and an endometrial biopsy to exclude endometrial carcinoma. Besides atypical glandular cells and endometrial cells, there are lots of squamous cell abnormalities that you can detect with a Pap smear. Remember, the goal of the Pap smear is to detect squamous cell carcinoma, the most common form of cervical cancer. The most benign form of squamous cell abnormality is called an atypical squamous cell. There's a subtype called atypical squamous cell US, which means atypical squamous cells of undetermined significance. There's also a subtype ASCH, which means cannot exclude high-grade squamous intraepithelial lesion. And then beyond atypical squamous cells, you can see cells consistent with low-grade squamous intraepithelial lesions or high-grade squamous intraepithelial lesions. And when women have these findings on Pap smear, this always indicates potential cervical neoplasia. What you do next depends to some degree on the woman's age and HPV testing if available, but in general, high-risk findings are always followed up with colposcopy. Sometimes if a woman is young and her HPV testing is negative and it's a low-risk finding like ASC-US, it's not necessarily followed up with colposcopy, but in general, most women who have these abnormal pap smears get a colposcopy to exclude cervical neoplasia. So that's a nice segue into the follow-up testing for abnormal pap smears. The standard test is colposcopy with biopsy. This involves using a colposcope, which is a fancy magnifying glass. It allows you to get an illuminated, magnified view of the cervix. This is usually done after an abnormal pap smear, or sometimes it's done in women who have abnormal findings on pelvic exam that suggest a possible cervical lesion. When you do a colposcopy, the cervix is washed with acetic acid. It will make neoplastic cells appear white. And so if you look at this drawing on the screen here, this is what cervical neoplasia can look like. You can see these white plaques. The thicker the white area, the more advanced the lesion is. During a colposcopy, areas consistent with dysplasia are biopsied. So this includes areas where the epithelium appears white after applying acetic acid. Also areas where you see a funny vascular pattern. If there's an abnormal or mosaic vascular pattern to the cervix, that can indicate neoplasia. Also any punctate or satellite lesions, which basically means any isolated areas where the cervix appears abnormal. Any of these findings can indicate neoplasia and should lead to a biopsy of those areas. And then it's high yield to know that you must visualize the entire squamocolumnar junction for a colposcopy to be considered satisfactory. If you don't see the entire junction, then it's an inadequate colposcopy. Remember, most cervical cancers occur at the squamocolumnar junction, and so if you don't visualize it, what that means is that the junction is in the cervical canal beyond where you can see with your eyes. So when you're unable to visualize the squamocolumnar junction like what's shown on the slide, then what you have to do is take a sample of the endocervix, the cells that are within the cervical canal. This is done through a procedure called endocervical curettage. And the idea here is that the junction is inside the cervical canal, so you take a sample of those cells because that's where you want to look for evidence of malignancy. Okay, so now we've talked about how you can do screening with a pap test, and we've also talked about how abnormal pap tests are followed up with colposcopy and biopsy. Well, what if the biopsy shows evidence of cervical neoplasia? Let's talk about the management of that now. First of all, it's super high yield to know that all patients who have an abnormal cervical biopsy should receive the HPV vaccination. The presence of LSIL or HSIL are not contraindications to vaccination, and there is evidence that vaccination may prevent progression to cervical carcinoma. Beyond vaccination, what you do next depends on the severity of the lesion. For low-grade squamous intraepithelial lesions or CIN1 lesions, usually these are managed through observation. 1 year later, you can repeat the colposcopy and also the HPV testing, and the idea is that these low-grade lesions, some of them will clear within a year, and the lesion may regress. If the follow-up colposcopy shows persistent abnormalities, then you can perform a conization, which we'll talk about in a second. If the biopsy shows a high-grade squamous intraepithelial lesion, a CIN2 or 3 lesion, then this is usually followed with cervical conization. This is a surgical procedure where a cone-shaped portion of the cervix is removed, and the idea is to excise the entire transformation zone, which is the zone where the cervical neoplasia is usually contained. This is both diagnostic and therapeutic. It's diagnostic because you can see the full extent of the lesion to see if it's more advanced than what the biopsy suggested, and it's also therapeutic because hopefully you remove all the neoplastic tissue. This usually requires general anesthesia, and there are a couple of ways it can be done. One is through electrocautery, which involves using an electrical knife technique called a loop electrosurgical excision procedure, or a LEEP. The other option is to use a scalpel. This is called a cold knife biopsy. There are also ways to do this using a laser. After a woman has had a conization, there are some potential complications, and it's high yield to know about these. First of all, the cervical canal can become narrowed. This is called cervical stenosis. So if you look at this drawing, if this canal becomes narrowed, then menstrual flow cannot proceed out of the uterus, and this can lead to dysmenorrhea. Also, after a conization, women can have cervical insufficiency, which can lead to problems in pregnancy, including preterm birth, and I talk about this in the obstetrics section. After a woman has had conization, the follow-up is usually testing at 6 months. Ideally, you test for HPV if it's available. If not, you can do a pap test. But the idea is that the testing should be negative after treatment because you've removed all the tissue that was infected with HPV and that was neoplastic. So this slide just summarizes the progression of testing in cervical cancer workup. Make sure you have this algorithm straight in your mind. It comes up on rotations and boards. So screening is done with the Pap test or the HPV test or the co-test. If that's abnormal, it's followed up with colposcopy and biopsy. And if you have evidence of a high-grade lesion, that's followed up with conization. If the biopsy or the conization shows evidence of cervical carcinoma, meaning malignant cells that have broken through the basement membrane, then the management begins with staging using CT scan or PET scanning to determine the spread of the tumor. The treatment is based on the stage of the tumor, which is determined by the amount of local spread and metastases, and the treatment can involve surgery, chemotherapy, or radiation. We do screen for cervical cancer during pregnancy, and the screening indications are the same as in non-pregnant women. So if a woman presents for evaluation of pregnancy and she has not had a Pap smear or an HPV test in several years, she should get that test because you want to know if she has evidence of cervical cancer as you manage the pregnancy. Abnormal screening tests are followed up with colposcopy, but a biopsy is done only if the lesion appears high grade. So if the lesion has findings like raised thickened masses or ulcerative lesions, and these suggest a high grade cervical lesion, then you would perform a biopsy. Otherwise, biopsy is not done because it could put the pregnancy at risk. And then beyond biopsy, excision with conization is only done if invasive disease is identified. Otherwise, you monitor the woman throughout pregnancy and do further evaluation and testing after the baby has been delivered. And then I'll finish with one slide on the HPV vaccine. I talk about this in detail in the video on vaccination in the pediatric section. So there has been a 9-valent vaccine available in the US since 2016. It's called 9-valent because it protects against 9 subtypes of HPV, including all of those listed here, and this includes type 16 and 18, which are the 2 most dangerous types. According to the guidelines of the Advisory Committee on Immunization Practices, children should receive the HPV vaccine at ages 11 to 12 years. It's a stronger recommendation, a 1A recommendation for females, but there's also a 1B recommendation for males because HPV infection can occur in men as well. And then this is a nitpicky detail, but it's super high yield to know this for your shelf exams. If you start the HPV vaccination protocol before 15 years of age, it requires 2 dosages, one at time 0 and a second dose at 6 to 12 months later. If, however, you start the vaccination protocol after 15 years, then it requires 3 dosages, one at time 0, another at time 2 months, and another at 6 months. And there are many women who present for HPV vaccination after age 15, for example, when they've become sexually active at an older age, and so it's high yield to know that in that situation, after 15 years of age, HPV vaccination requires 3 doses. And that concludes our module on cervical cancer.